Dr. Prabhakaran, Dr. Gibson coming to you live from AHA 2024, and we're talking about the TOPSPIN trial, a trial of a combination pill to treat hypertension in India. Talk to us a little bit about what you found.
So we compared combinations of three combinations of two drugs, amlodipine and a diuretic and an ACE inhibitor, and an amlodipine and an ACE inhibitor. So our hypothesis is that there will be differences because based on the Creole trial, there were differences in terms of ACE inhibitor trumping over the others. Amlodipine trumping over the other combinations. But we did not find that in our trial. In fact, all the three drug combinations reduced the office blood pressure by 30/15 on an average, which is huge. And also the ambulatory blood pressure by around 15 millimeters systolic or so. So clearly, any of these three combinations work. And I think that's a good news. It simplifies treatment and it actually kind of adheres to all the guidelines that we have, which say that you can use any of these three combinations.
So tell us what the combination pills were again, just so I'm clear.
So we had a combination of amlodipine and perindopril and indapamide, and amlodipine and indapamide. That were the three combinations.
Same benefit of all of them? Any differences? It was the same effectiveness for all of them?
Absolutely the same effectiveness, no differences. Same effectiveness, very low adverse event rate, just 3% adverse event, and no differences even in terms of the adverse event. The only thing which was there, could be hypothesis generating, was the HbA1c levels were lower in the amlodipine arm of the trial.
Did you expect that, or do you think that's real, or is it spurious?
I mean, whenever we look at beyond primary hypothesis and non-hypothesized findings, you have to always assume that it's because of chance. But there is a biological rationale that diuretics can cause a bit of hyperglycemia, can increase hemoglobin A1c. So in a sense, that combination of amlodipine plus perindopril had a little lower HbA1c, but I would treat this as hypothesis generating rather than hypothesis proving.
So do you think polypills are cost effective and will take off in India?
Yeah, polypills are definitely cost effective, but we do have combination pills for multiple things. In fact, we do have combinations with aspirin, we have combinations with statins and several other drugs. And in fact, a recent meta-analysis, individual patient meta-analysis conducted by McMaster, by Professor Salinos's group, and I'm also a co-author of that, showed substantial reductions in mortality, particularly in the realm of primary prevention. Even in secondary prevention, there's increased adherence and decrease in MACE. So clearly polypill is useful, but there is a resistance to the use of polypill from physicians, as well as the pharmaceutical companies are not too enthused by polypills, particularly those that have gone off patent.
And how can we overcome the physician resistance? Why is there resistance? Is it the inability to titrate or individually manage some of the individual drugs? Tell me why there's resistance among the docs.
So in one of the earlier studies, when we looked at qualitatively, we spoke to many physicians. One big fear they have is the fear of losing autonomy. They fear that, this is too straitjacketed. We just have to give this medicine and see. The second is the fear of side effects. They think that what happens if the patient stops the drug suddenly? So they think that it could be disastrous. Then the third thing is that they don't have the independence to prescribe something that has come up new because it's kind of straitjacketed into generic drugs. So these are some of the issues which have come up when we have discussed it with them.
So it sounds like the next step maybe is more implementation science, how to get people to adopt this kind of pill. Thanks so much for sharing all this. Good luck on the implementation piece. Our science is only as good as our implementation science. Thanks for joining us today, and thanks to all of you for joining us here from AHA 2024.